Dr. Raja, we will wait for Dr. Imran first for 5 minutes. After 5 minutes, he didn't turn up, we will start lah.
Okay, no problem.
So for attendees, thank you for coming to this webinar. We will wait for our chairperson to come, and maybe another around 4 minutes. And after that, we will start lah if he didn't turn up yet. Thank you.
Hi, a very good evening to everyone in attendance. Welcome to the third week of the College of Physicians webinar for the topic of cardiology. For the week of cardiology, and the topic today is overview of heart failure across all spectrums of ejection fraction. Our chairperson for today, Prof. Imran, he's actually caught up with a procedure at the moment, so he will be joining us slightly later. So I'll proceed to actually introduce our speaker for today, Dr. Kendeswari Raja. So, Dr. Kengis is a cardiology fellow at Hospital Raja Permaisuri Bainun, Ipoh. She graduated from Malacca Manipal Medical College in 2007 and obtained her MRCP in 2017. She also has a diploma in dermatology obtained in the year 2014. Dr. Kengis is currently in charge of the multidisciplinary heart failure team at Hospital Raja Permaisuri Bainun, Ipoh, and she has been a speaker for various heart disease related topics in the state of Ipoh. She has also presented internationally at the ESC conference in Lisbon in May this year. So without further ado, Dr. Kengis, the floor is yours.
Thank you, Dr. Vidya, for the kind introduction. I'll share my slide first. Is the slide visible?
Yes.
Yeah, okay. So I hope everyone will stay awake, but I think it's raining in most of the place now. Okay. So the task given to me is to talk about heart failure across all spectrum of EF as an overview. I'm sure lately there's a lot of talk about heart failure and there's a lot of importance given to heart failure patient compared to last time. So we will start off with case presentation. I have two case presentation. The first case, we start off with a 45 years old gentleman who's an active smoker. He is a type 2 diabetic with hypertension. He had history of anterior MI in January 2021. Coros were done and noted single vessel disease where LED was 70 to 80% stenosis, PCI done to LED. Subsequently, he was quite well until lately he presented to us with 5 months history of failure symptoms. He had NYHA class 2 to 3 with limited daily activity. If you all can see the echo images, the ejection fraction is very poor, is about only 20% with globally hypokinetic with thin out septum. Now I'll go to the second case first before we discuss further about how we manage this case. So the second case, we have a 71 years old lady who's been obese with a BMI of more than 30, dyslipidemic, and also AF on no egg. Her coronary, she has mild coronary artery disease where the coros was done in 2019. She presented to us with reduced effort tolerance with bilateral leg swelling for the past 1 year, and she is in NYHA class 2. So if you see echo, the echo shows the ejection fraction of 60%. There's no regional wall abnormalities, but there's noted to have diastolic dysfunction. And she also have been admitted multiple times for these failure symptoms. So from these two cases, what are the similarities that we can see in these two cases? First, both patient has failure symptoms, but both have different LV ejection fraction, which makes them in two different groups. Hence, the treatment management will differ for both of them. So how to go about this now? So before we go to the treatment of the two patients, I would like to just introduce the universal definition of heart failure. I'm sure all of you all know about this, just as a reminder or just to remind you all what is heart failure definition is all about. So if you want to define a heart failure, the patient should have symptoms and or sign of heart failure caused by a structural and or functional cardiac abnormality with at least one of the following. Either the patient should have an elevated pro-BNP or they should have a objective evidence of cardiogenic pulmonary or systemic congestion. This can be either current or in the past, and it have to fulfill the criteria for the elevated nitric peptide level, where for the ambulatory patient it must be more than 125, and for hospitalized and decompensated patient must be more than 300. And when it comes to objective evidence, they should have some diagnostic modality like imaging, where the chest X-ray or echocardiograph, which also suggests of heart failure. And I'm sure all of you all know about this universal definition of heart failure based on LVEF. So there's three main groups, which is a heart failure reduced ejection fraction, which is the ejection fraction must be less than 40. Heart failure mildly reduced ejection fraction with a range of 40 to 41%, 49%, and heart failure preserved ejection fraction, where the ejection fraction must be more than 50. And there's also another entity which we call as heart failure improved ejection fraction. This is mainly for a patient with reduced ejection fraction where their baseline ejection fraction is less than 40. At any point of time, if there is more than 10-point increment from the baseline or the second measurement is more than 40%, this patient you can label them as heart failure improved ejection fraction. As you all know, why there's so much of talk and so much of importance given to heart failure. This is because heart failure is a worldwide burden. If you can see everywhere, the admission for heart failure have increased with at least 60% of the patient required inpatient care. When it comes to Malaysia, if you can see, Malaysia has the highest prevalence of heart failure admission, which is at about 6.7% compared to other countries. Even US is only 1.5 to 1.9. And recently, as Vidya mentioned just now, Portugal, I went for Portugal for the ESE presentation. Even Portugal only have 1 to 2% prevalence only. Malaysia has the highest. And our neighboring country, Singapore, also only has 4.5%. Even our national registry also shows that the prevalence of heart failure in our cohort, it's mainly a reduced ejection fraction. Probably during the time when this registry was done, we didn't have a proper classification guideline for a preserved ejection fraction. So probably the preserved ejection fraction, I think it's underdiagnosed in this registry. Probably in the near future, we will have a clearer picture of the proportion of heart failure preserved and reduced ejection fraction in our country. And if you can see male to female proportion, male predominant in all the group except for the preserved ejection fraction heart failure where the female were more. So why all this is important is with every admission, the patient have a risk of recurrent event and even death. So time is gold when it comes to heart failure patient, not only for MI patient, but heart failure patient also, it's very important. We capture them at the right time. So this is because patients with heart failure have a very high rate of mortality. If you can see, if a patient admitted for acute heart failure, in hospital mortality itself, they have 4 to 7% risk increase compared to a normal patient. And that risk doesn't stop there. At 30 days of discharge, they have about 10% increased risk for mortality. And at 1 year, 20% increase. And at 5 years post-diagnosis, they have up to 50% increased risk of mortality after they have actually been diagnosed as heart failure. So this is because with every acute event that the patient got admitted for heart failure, there will be an additional damage to their myocardium, which actually reduce their lifespan. So it is always important to catch them at the beginning and optimize them with the medication so that we can prevent them to have further myocardial damage. So when it comes to the patient with heart failure, we have actually multiple goals. So I will name mainly 4. First, we want to prevent them to get hospitalized again. We want to reduce their mortality. We want to improve their clinical status. And we also want them to have a good quality of life and functional capacity. So now we go back to our case 1. As you all know, the case 1, it's actually falls in the category of heart failure reduced ejection fraction. Just a recap, this is the story of the first case. So as you all know, I'm sure you all know about this fantastic 4 medication that we have. So when it comes to heart failure reduced ejection fraction, it's very important. We have to start, the first pillar is inhibitor or ARNI. A second pillar, which is the beta blocker. Third pillar is the MRA. And the fourth pillar, which is the latest pillar, is the SGLT2 inhibitor, sorry. So this is very, very important that we start on our patient, all 4 pillars. There's no more GDMT sequentiation anymore. So it is actually important to start all these patients with all these pillars as soon as we diagnose them at heart failure. if possible, during their hospital admission itself. And we have to optimize all these pillars within 6 weeks of diagnosis to improve their and improve their quality of life and to reduce their risk of mortality. So, like I said, why there's so much talk on GDMT? Because if you can see this chart, I got it from National Heart Foundation of Australia and New Zealand. If you can see, if you just start the patient on single pillar, which is ACE inhibitor, there's actually 17% reduction in all-cause mortality in a patient with heart failure in 1 to 3 years. But when you increase it to 2 pillars, the reduction is even more. So you reduce by 43%. And when you increase to 3 pillars, when this study was done, it's only up to 3 pillars. If you can see, there's 56% reduction in all-cause mortality in patient with reduced ejection fraction heart failure. So it's always important to start all 4 together, and if there's no contraindication. So now we come to the second case. So second case, as you all can see, she's obese. She's having dyslipidemia, AF or no egg. Probably all of you all will think that, her ejection fraction is quite good, but why she's having worse symptoms? Her symptoms, her NYHA class was 3 to 4, limiting her from the daily activity. This is probably because of this. I'll just explain this picture. If you can see the reduced ejection fraction heart failure, the heart function itself already less than 40%. So what happens is when the patient have reduced ejection fraction heart failure, the left ventricle only fills with very small amount of blood, and it only can pump up to 40% of its volume before refilling. So that's why in a patient with reduced ejection fraction, they have symptoms of heart failure. When it comes to preserved ejection fraction, even though their heart function ejection fraction is good, because of the left ventricle is stiff and it's most of the time has a thick wall, what happens is whatever amount of blood which is filled up, it's only small amount, and even if it pumps out the whole blood out, it won't be enough to meet what the bodies need. So that's why sometimes if you can see patient with preserved ejection fraction, their symptoms will be more significant compared to actually to reduce ejection fraction patient. So for the preserved ejection fraction, as you all know, I think all of you all know about this chart. This is like a scoring system which can actually tell us whether the patient really is having a preserved ejection fraction heart failure or not. So the drawback in this chart is most of us don't have an echo that we can get immediately. So sometimes when we see a patient in the ward, probably we won't get the echo that time. We can only get it when we are seeing the patient in outpatient. And some hospital, I think they are also having issues with pro-BMP. So in a hospital that you can get an inpatient echo and you can do an inpatient biomarkers, I think you can very well use this chart. And if the patient fulfills the criteria for the functional, morphology, bio and the biomarker, and if their points is more than 5, then you can label them as heart failure preserved ejection fraction. But when it comes to a place or the clinic where they can't get echo easily, so what I would suggest is a bedside echo just to see whether the ejection fraction reduced or it looks preserved is enough. Then once you actually saw the ejection fraction looks like it's preserved, you can use this chart, which actually gives you point based on patients, whether patient is heavy, patient's comorbid like hypertension, atrial fibrillation, and if you have a pulmonary hypertension based on the echo, that also can be used, and the age and the feeling pressure. So in a center that you can't get a biomarker, I think this will be a good scoring system that you can use to treat your patient. So when it comes to the treatment of preserved ejection fraction, if you can see, class 1 indication is SGLT2 inhibitor only. When it comes to the diuretics, only given to a patient who has fluid retraction and in NYHA class 2 to 4. So we will start off with loop diuretic agents. And in a woman with all EF and the men with EF less than 55 to 60%, and those who had fluid retention, you probably can add MRA, but it's only class 2B indication, because why? Most of the heart failure preserved ejection fraction patient has a few phenotypes. Some patient do well with MRA and some patient actually can't tolerate it and probably the symptoms will worsen. So until the proper study on each phenotype of the heart failure preserved ejection fraction is out, I think we can probably use this as a guide, especially when your patient is very symptomatic. No harm trying. But the most important part is to give SGLT2 inhibitor first. And you also can add ARNI in a patient where either they cannot tolerate, if they cannot tolerate ACE or ARB, but they have accessibility to ARNI, you can add them ARNI, which can also help in preserve ejection fraction. And due to cause or intolerance or to ARNI, you can give them ARBs. So now, we all know the treatment of heart failure preserve and reduce ejection fraction. But now, mainly, I'm going to give a troubleshooting for heart failure reduce ejection fraction. Probably all of you all have gone through all these problems. You have a patient with a low blood pressure with a worsening kidney function, but they also have heart failure, reduced ejection fraction. You know you have to give all the 4 pillars of heart failure. But when you start on the 4 pillars of heart failure, probably the blood pressure will go down further or the kidney might worsen further. So how to go about this? So first I will start off with in a patient where they have a blood pressure problem. So I got this chart also from the National Heart Foundation of Australia and New Zealand, and I'm using this in my daily practice. So let's say your patient have a asymptomatic hypotension. You're seeing a patient with a blood pressure of probably 80 plus systolic and about 50 plus diastolic. But the patient can walk into your clinic, he got no giddiness, he's completely well. Please continue the current uh, management. That means you continue their ACE or ARB or ANI, continue their beta blocker, continue their MRE. But let's say your patient is symptomatic. The patient says that he has a headache, lightheadedness, and also confusion or dizziness. So in that condition, what you should do is first assess the volume status, because some of these patients probably we have included loop diuretic, which we would have asked them to continue without stopping. So what you can do if the patient is not overloaded, you probably can ask them to stop the diuretics and also see whether this patient is also on other medications like for hypertension or even nitrates for their IHT previously. So if let's say all this is not required or you think the calcium channel blocker is in a very high dose, probably you can withhold or reduce the dose first without stopping our ACE, ARB, ARNI, and beta blocker. But let's say despite you checked all that, the patient is still symptomatic, like the patient don't have any calcium channel blocker, they are not on nitrate, and the diuretics are only in PRN basis. What you can do is you can temporarily reduce the dose of the ACE, ARB or ARNI or even the beta blocker. But a lot of center, I think we use bisoprolol as a beta blocker, which I think has a very small effect on blood pressure if it is not in the maximum dose. So I think when it comes to bisoprolol, and if my patient is symptomatic hypotension, I will try to reduce the ACE, ARB or ARNI first rather than the beta blocker. After reducing, probably you can review this patient in a week. And if it's still symptomatic, probably you have to cut the dose further or you have to take off one of the medication. But when it comes to MRA, it is suggested to continue the MRA because you will try to cut down or reduce the dose of the ACE, ARB, ARNI, and beta blocker. And you only will touch MRA when, despite you already consider cutting all these medication, patient is still hypotensive and they are very symptomatic. Then you probably can cut down the MRA. I've actually given a spinal ectomy of only 6.25 for some patient who really cannot tolerate any of this medication. And when it comes to cardiogenic shock, as you all know, no choice, have to withhold everything and refer to a tertiary center. So now, When it comes to renal function, most of our medication, especially our ARNI and also even SGLT2 inhibitor, immediately after you starting, there will be a dip in the EGFR, then it will get better. So if you see a patient with the EGFR decrease less than 30% from their baseline, so what you have to do is just continue the MRA, you continue the ACE, ARB, ARNI, and you continue the beta blocker. Because a lot of time beta blocker has no effect on the EGFR. Most of them are safe to be used even in patient with worsening kidney function. When you have the EGFR decrease, but it's more than 30% from the patient's baseline. So same scenario, you have to assess the volume status. You have to review whether the patient is on any other medication. Like I said just now, the patient probably on a diuretic or patient is taking some NSAID or in our country setting, a lot of time patient will take some herbal products without we knowing. So we have to get a detailed history. If let's say all this is none, what you can do is for MRA, you can reduce the dose, and for ACE, ARB, or ARNI, maybe you either reduce the dose or stop it, depending on how bad is the EGFR. And when it comes to hyperkalemia, if you see a patient with a potassium more than 5.5, same thing again, assess the volume status first and see whether is there any other medication which is causing the patient to have hyperkalemia. If none of the above, for MRA, you can probably reduce the dose, and for ACE, ARB, ARNI, you probably need to decrease or stop temporarily until the hyperkalemia resolves. And beta blocker just continue, no issues. And in hyperkalemia more than 6 millimole per liter, you probably need to just stop the MRA and probably discuss with your specialist or a heart failure team whether anything can be done. And for ACE, ARB, and ARNI, you can follow the previous step. Either you reduce the dose or you temporarily stop. Okay, so when it comes to creatinine, that was all about EGFR hyperkalemia. But let's say the creatinine, if you have a patient with increase in creatinine but less than 30% from your baseline, you just have to continue all this medication and probably have to see the patient a bit more earlier, because sometimes this patient tend to have a worsening kidney function later. So I think it's quite short, but in summary, these are the pillars of heart failure. So if you can see in heart failure, reduced ejection fraction is very, very important to have all these 4 pillars. Guideline, especially JACC 2024 guideline actually suggested we have to start ARNI as a first line first, but we have to follow our country. In Malaysia, I think most of the place we can't get ARNI, so ACE or ARB still plays a role. And in a patient who are symptomatic, despite on ACE or ARB, you can start them on ARNI and MRA, beta blocker, and SGLT2 inhibitor. When it comes to heart failure, mildly reduced ejection fraction, same also is ARNI, ACE, ARB, MRA, beta blocker, and SGLT2 inhibitor. And when it comes to heart failure, preserved ejection fraction, actually class 1 indication is only SGLT2 inhibitor. The rest are all class 2B. Thank you.
Okay, thank you very much, Dr. Kengis. So I think we have Prof. Imran joined us already. Hi, a very good evening, Prof. Very privileged to have you today. So sorry that we have to take time off from your busy schedule to join us today. So we'll just wait for questions from the floor, if there's any. And in the meantime, Dr. Kengis or Prof. Imran, you have anything else to add, you can share it with the participants, or any take-home message. I think Dr. Kengis has did a very good summary of the heart failure across all EFs and the treatment management. And I think something which is very important was the part on the BP, because I think that is one of the challenges we face. Patient comes in with a poor EF, the BP is always a problem, and then we have problems titrating the medications. I mean, the 4 pillars, the GDMT. So feel free to ask us questions, and Dr. Kengis and Prof. Imran will be more than happy to answer. I think so far there are no questions yet. But we will probably wait for another 2-3 minutes.
I'm surprised there's no questions, so I'm not sure whether
Yeah.
people listening.
Hi, Prof. Imran here. Can you hear me?
Yes, Prof.
Sorry, a bit late joining. I got a tough SVT to manage, but I managed to ablate it already. So wonderful lecture just now about heart failure and how to whatever I could catch now. Now, tell me about the 4 pillars of the heart failure. Yeah, these 4 pillars. How do you initiate these 4 pillars of in a new patient with a newly diagnosed heart failure?
Thank you, Prof. Okay, so basically, I will try to divide into whether the patient admitted for a acute heart failure or we are seeing in an outpatient setting. So when it comes to the one admitted for acute heart failure, sometimes they'll be very ill. They probably required inotrope and all. So usually, what we will do is we will wait until they are more stabilized. At least they are at least for 24 hours or 48 hours without any inotrope. Start off with, if they are not overloaded, I'll start with beta blocker first. And if their kidney function is okay and their BP is okay, with SGLT2 first. But before they are discharged, I will try to at least include 3 pillars, especially at first. Because sometimes like the BP are borderline, I can't include MRA plus ACE or ARB at the same setting. I will at least give them 3 pillars, but if can, I'll try to push for all 4 pillars lah. But when it comes to the patient in our clinic, based on their blood pressure and how is their kidney function. So if their kidney function is okay, their blood pressure is okay, most of the time our patients is already on 1 or 2 of the pillars. So I will just add on the balance pillars as per guideline.
Why is it important for us to add in the pillars of these drugs quickly? What is the rationale of us
Okay,
doing?
so actually, as we can see, we want to halt the adverse event. So because if a patient admitted one time for the heart failure or any adverse event of the heart failure, if the heart pillars are not optimized, they have very high risk of mortality and also 30 days readmission rate for recurrent heart failure. So we want to prevent this, because if you don't prevent this, we are actually reducing their lifespan. And in the long run, the patient, if they are admitting multiple times, their lifespan are reduced markedly compared to a patient who are on 4 pillars and they are not admitted. So it's very, very important to reduce their risk of mortality by adding all these 4 pillars as soon as possible. And even our ESC guideline says to titrate it up and to optimize within 6 weeks.
Excellent. So we have to do this within 6 weeks.
Yeah.
And therefore, these kind of patients needs to be seen earlier lah.
Yes, correct. So even in our
What do you think about how we are doing right now? Are we optimizing our heart failure patient? How many percent do you think of our heart failure patient receive optimized medical therapy?
Okay. Okay, that one is a very difficult question, but
Just
overall, I
agak-agak
don't
lah.
have a data, but overall, I think we are not achieving, even in the overseas country also, the prescribing rate for all the 4 pillars, it's not so great. It's not 100% yet. But I think in Malaysia, the drawback is, one is a lot of our hospital, when it comes to SGLT2 inhibitors and all, we have a very limited quota. So if the patient can't afford to buy themselves, we have to wait until we get the quota. So, but while waiting, they'll be probably only on 3 pillars, not the 4th pillar. And some patients, when they come to us, also they come very late. So when they come very late with a very low BP, sometimes some people are a bit afraid to start all 4 pillars. And another thing is, when the appointment are given to the patient to be seen early, some don't turn up. So hence it was not optimized. And I think the 4th reason would be Some of the specialists or some of the MOs who seeing the patient, when they see the patient is comfortable, the NYHA class 1, so they don't up titrate. They think, oh, patient is comfortable, so I'll just maintain it. But that is not supposed to be the way. We have to optimize it to patient's maximum tolerated dose. That's most important.
Excellent answer. Actually, we have data on this in our heart failure registry. And it is seen that only 20% of heart failure patients actually have optimized medical therapy, meaning that on 4 drugs at maximum dose tolerated.
But Prof, sorry, our registry is 2019 one, right? We don't have a latest one yet, right?
Not yet. So
Yeah,
that is
so that's
whatever
why.
we have right now.
Yeah.
So at least within that before the COVID era.
Yeah, the
So we are
before
not doing
COVID.
very well. Yeah. We're not doing very well when it comes to optimization. And you know, among all the drugs that is the least optimized between the RAS inhibition, beta blockers, spironolactone, and the SGLT2. Among these 4 drugs, the drug that we often don't optimize is the beta blocker. Often the beta blocker is left at a dose, for example, in bisoprolol, left at 5 milligrams. In actual fact, among all the 4 drugs that needs to be optimized to maximum dose, the most important drug that needs to be optimized is the beta blocker. Somehow we are not doing that. Somehow we feel when we have achieved the rate of certain rate, for example, 60 beats per minute, we stop treating the drugs. We are not treating the heart rate. We are blocking the adrenal effect on the heart. The beta blocker must be given to the maximum dose tolerable. Hence, if it's a bisoprolol, you have to reach 10 milligrams. Unlike Entresto, for example, the results that you get with 100 or 200 milligrams, more or less, is the same. Of course, that's slightly better with 200, but not with 100. So, for the participants listening to this lecture, one thing I need to emphasize that look at your beta blockers. Try and maximize it, and do not limit your heart rate as a reason for you not to titrate the beta blockers.
Thank you, Prof.
How often do you look at ECGs for optimization of heart failure, Kengeswari?
Optimization of medication, is it that? So,
ECGs.
okay, the baseline
What's
we
the
will
role of doing ECGs in heart failure management?
Okay, to tell the truth, baseline they will have, and then maybe in 2 or 3 months' time, I will repeat another one, but not so frequent.
Why do you think that we need to do more? We need to, from time to time, look at the ECG.
I want to see their QRS complex, whether they are suitable for CRTD or whether they have any PVCs. They want to see the burden, whether they need for ICD, even though it's supposed to be class 1 indication. But in government hospital, we don't get it for class 1. So, I mean, for the primary prevention, so we can only get it for secondary prevention.
Excellent. The idea is to always look for the opportunity
Yes,
to do pre-synchronization.
yes.
Patients with heart failure with widened QRS complex, especially the left bundle branch block, they stand a better chance for recovery from their heart failure compared to those with narrow complex QRS. It is therefore an opportunity for us to manage the patient to achieve better reverse remodeling. I see there was a question just now, yeah?
Yeah.
Oh,
Yeah, there are actually 2 questions. I'll read out the first question. For newly diagnosed heart failure with echo pending, would you start ACE or beta blocker first if the BP is lowish, for example, 120/80?
sorry, again, the question?
Sorry, they said if a patient has diagnosed with newly diagnosed heart failure where the echo is pending, would you start an ACE or a beta blocker first if the BP is lowish, for example, 120 over 80?
120 not low, so I think I'll
Yeah.
start both.
So the question was that. So ACE or beta blocker first?
I'll start both. Like I said, there's no more sequential. You have to optimize all four whenever possible.
Okay, and then we have a second question for Prof. Imran.
Hey, wait, let me answer this one.
Okay.
Let me give my opinion also lah. Okay, I think when you have BP which is lowish like this, and you have suspicion of heart failure, but you don't know whether this is a reduced ejection fraction or preserved ejection fraction. Okay, so you have a heart failure, you don't have an echo, you don't know yet. Of course, the universal drug for heart failure should be started first, which is the SGLT2. So that will be my first drug that I will add on. Okay. Maybe if the BPC lowish, I can add in a bit of spironolactone while I diurize the patient a little bit. Once the patient is a little bit drier, then I can consider starting on ACE or beta blocker. Okay, so that will be, I start on those that I can start easily without interrupting the blood pressure. At least you have one of the
I don't have
pillars in.
access to a lot of SGLT2 inhibitors.
Yeah. I use a lot of SGLT2 because they really have rather quite a good effect, and it's quite immediate. The rehospitalization really drops once you start on SGLT2. Okay, the next question.
Vidya, what is the next question?
That's a question for me, isn't it? I
Yeah.
saw one. I don't know where it is.
Yeah, it's when missing.
When missing. Or
I can
maybe
only
it's in
see
the
the
chat.
one question.
It's in
Yeah.
the chat, I think.
They deleted the question, Prof.
Or delete. Oh, why?
Or maybe it's
Ask
there.
me
Let
lah
me check. Let
question.
me see whether it's somewhere else. Oh, okay. Actually, they put it in the webinar chat. So the question was, what is the acceptable heart rate in heart failure patient if we need to optimize the beta blocker? Will the patient come with bradycardia symptoms if heart rate very low?
Okay, so very good question. Just now I say you don't worry about heart rate, you up titrate lah. So my acceptable heart rate for patients with heart failure would be around not lower than 50. Okay, not lower than 50. Often when you up titrate the beta blockers, you already have a heart rate of 63 or maybe a high 50s. If you up titrate the beta blocker, it doesn't go like very sampai you go complete heart block. No, it doesn't happen that way sebenarnya. Yeah? So, but if your heart rate is less than 50, I wouldn't touch it. Then I wouldn't touch the beta blocker anymore. My cut-off is around 50. Of course, you have to look at the patient symptoms as well. But rarely, be above 50, between 50 to 60, patient have any symptoms of dizziness unless the blood pressure is low. Yeah, so I will take it at 50.
Thanks, Prof.
Thank you, Anis Nabila. Thank you for asking. Any other questions, guys?
Yeah, I don't see any other question, Prof.
Yeah, there's no more questions actually in the box.
Oh, got one.
One more.
Okay, in a patient.
Nice. Nice question.
Okay, so I'll read out the question. For patients who have hyperkalemia above 6, how long do we withhold the MRA and when to repeat the renal function before restarting the medication?
Prof, you want to give expert opinion?
Okay, so we have a lot of these issues sometimes when it comes to high potassium and MRA lah. So normally I will stop the drugs for about 5 days in a clinical trial. But of course, in a clinical practice, it's a bit difficult lah kan. So I will stop for the MRA for 1 week. And of course, will advise on the patient, to the patient about the diet, etc. And if need to, I will start on a regime. Okay. Then only I would reintroduce the MRA at a lower dose after getting the potassium level below 5.5. Okay, so about 1 week only. In clinical trials, we stop it for about 2 to 5 days. But in the real world, 1 week. Call the patient back in 1 week for repeat potassium level. Okay. Now, recently we have new drugs available for hyperkalemia. Okay. Nokelma. And it's a bit expensive, but Nokelma gives us the opportunity to maintain the potassium level at an acceptable level with the use of MRA and RAS. Okay, it is available in some hospital as samples, but whenever it's available later to you guys, you can use Nokelma to help keep the potassium at an acceptable level. Because the use of resin has a lot of side effects and it's not good to be giving patient long term. So yes, if you do have recurrent episodes of hyperkalemia, use Nokelma. There are some patients that we have that we give Nokelma as a on a daily basis or every other day basis.
Yeah, even in our practice also, we will be told for 1 week. We will, if the patient can come within 1 week, then we will repeat that in 1 week and see whether we can restart, or sometimes
Yeah.
2 weeks, depending on our availability, because it's very difficult to get everyone to come within 1 week.
Yes, yes.
Yeah. I think that's all, right, Vidya?
Kerja, maybe you're thinking. I'm sorry, I came in late. I don't know what's wrong with my video. It doesn't turn on. But it's okay, like, I can hear my voice.
Can hear your voice, Prof. Yeah.
Very
Yeah.
husky.
Yep. So I don't see any more questions on the chat box.
All right, then. I guess we can end here. What do you think?
Yes, we can end here if no
Yeah.
one has any more questions. So Dr. Kengis, any last few words? And Prof Imran, just last few words before we end this session.
Then yes, you go first.
Yeah, okay. Very important. I think this one I tell to everyone that I meet. Okay, for heart failure reduced ejection fraction, please start the GDMT as soon as possible. If can, all the 4 pillars at the first go, that diagnosis is very important. When it comes to preserve, yes, there's a lot of issues, but you can try with SGLT2 inhibitor first. For I know government hospital, there's a lot of issue, but if the patient is a pensioner and all, you can use the GPA option. So please try to see heart failure patient as a whole. You cannot just see them once and see back another 6 months later. That won't help the patient. If you want to reduce their readmission rate and if you want to reduce their mortality, you have to see them early to optimize. And please remember this figure, 6 weeks if possible, if not by 10 weeks, try to optimize all the GDMT. Thank you.
Okay, my turn. I think Kangas already said the most important thing lah. Again here, I would like to emphasize on use more interest too, not because I support Novartis or whatever. Although
Based on ACC guidelines.
expensive lah, sebenarnya expensive. But if you can encourage the patient to try, once they have tasted the effects of Entresto, they'll be willing to spend a little bit on the drug. Yeah. And my the other takeaway message: optimize your beta blockers to the max. Do not continue same. Optimize. Okay. Go to the maximum dose. All right. Okay.
Okay, thank you
We
very
can
much.
end now. Yeah.
Yeah, thank you very much, Prof and Dr. Kengis, for the very insightful talk. So we will meet again next week, everyone, for another topic in cardiology. Take care and have a good evening. Bye.
Thank you. Bye.